Hi guys, hello everybody. Let's clarify points concerning valvular inflammatory disorders. They are often under-recognized, misdiagnosed, or cause significant distress to patients. So let's clarify the key points that were misunderstood, confused you on the previous big board exam. So take your pens, papers to make the notes, and let's go. Okay, so valvular inflammatory disorders, and let's start with lichen sclerosis. Lichen sclerosis classically causes a figure of 8 or keyhole pattern of involvement around the vulva or perineal area. Okay, so vulva and perineal area. So figure of 8 or keyhole pattern of involvement around the vulva and perineal area. When it sounds like a fungal infection, lichen, it's an autoimmune chronic inflammatory condition leading to significant architectural changes. It can occur at any age, including pre-pubertal girls, where it's often misdiagnosed as abuse or poor hygiene. So clinical importance. Lichen sclerosis carries a 6% of lifetime risk of development valvular squamous cell carcinoma. This underscores the need for accurate diagnosis, long-term management with potent topical corticosteroids, and regular follow-up, including biopsy of any suspicious lesions. Untreated lichen sclerosis leading to scarring, resorption of labia minora, fusion of the clitoral hood, phimosis, and introital stenosis, so narrowing of the vaginal opening, causing severe dyspareunia, painful intercourse, and functional issues. Intense pruritus, itching, is the hallmark, but pain, burning, and dyspareunia are also common, and it can be mistaken for thrush, candidiasis, or simple dryness. Next, erosive lichen planus. Erosive lichen planus is a severe variant that can affect not only the vulva and vagina, but also the gingiva gums. Hence, the vulvovaginal gingival syndrome. The co-occurrence of oral lesions can be a crucial diagnostic clue. Lichen planus is an autoimmune T-cell mediated condition. Clinical importance of that. Patients experience intense pain, burning, raw erosions, and sticky, purulent vaginal discharge, often sterile actually. It can lead to severe vaginal adhesions, stenosis, narrowing, and complete obliteration of the vaginal canal if non-treated aggressively. Not correctly and aggressively, of course, aggressively. So diagnostic challenge can mimic other ulcerative or desquamative conditions like pemphigoid or even severe infections. Biopsy is essential. A little bit later about biopsy. So similar to lichen sclerosis, chronic erosive lichen planus has an increased risk of developing valvular squamous cell carcinoma, particularly in long-standing erosions. So, on the big exams, we have to answer like this as well. Look for lichen planus lesions elsewhere, oral cavity, lacy white Wilkham striae, erosions, skin, purple polygonal pruritic papules, plaques, scalp, scarring alopecia, and nails. Lichen simple chronicus is not a primary disease, but rather a secondary skin change resulting from chronic rubbing and scratching in response to an underlying itch, pruritus. The skin became thickened, lichenified, leathery, and hyperpigmented due to this repeated trauma. So each scratch, each cycle perpetuates the condition. Clinical importance of that. Successful management hinges on the identifying and treating of the initial case of the itch. For example, contact dermatitis, underlying lichen sclerosis, psoriasis, neuropathy, or even psychogenic pruritus. Yes, simply treating for lichen simplex chronicus changes with steroids without addressing the trigger leads to recurrence. Management involves potent topical corticosteroids to reduce inflammation and itch, emollients, and strategies to break the itch scratch cycle. For example, sedating antihistamines at night, cool compresses, behavioral therapy, you name it. So, lichen simplex chronicus can sometimes obscure an underlying condition like lichen sclerosis or valvular intraepithelial neoplasia. So, careful examination, my beloveds, and biopsy might be needed if the primary trigger isn't obvious or if it's refractory to treatment. Next topic. So the valvular skin is highly permeable and susceptible to irritants and allergens due to its thin stratum corneum, occlusion, hydration, and friction. Many so-called feminine hygiene products, scented soaps, detergents, douches, and even components of sanitary pads or topical medications can be culprits. Latex in condoms can also cause allergic reactions. Yes, it's happened. So, clinical issue of that, my beloveds. It's one of the most common causes of valvular itch and irritation. A detailed history of product use is crucial. Irritant contact dermatitis, ICD, is more common and occurs from direct chemical damage, harsh soaps, urine. Allergic contact dermatitis, ACD, is delayed type hypersensitivity reaction, for example, to fragrances, preservatives, nickel. Patch testing can identify specific allergens in allergic contact dermatitis. So the cornerstone of management is identifying and eliminating the offending agents. Mild topical corticosteroids and emollients can help soothe inflammation. Patient education or gentle valvular care is paramount. Valvular psoriasis often presents atypically compared to psoriasis elsewhere on the body. Instead of classic silvery scales, it tends to be well demarcated, erythematose, red, moist, and non-scaly plaques due to the occlusive and moist environment of the vulva. This is often termed inverse psoriasis. Why it's so important? Lack of typical scaling can lead to misdiagnosis and candidosis or seborrheic. So in this manner. Lack of typical scaling can lead to misdiagnosis as candidiasis or seborrheic dermatitis. So a personal or family history of psoriasis or any other autoimmune disorders, and looking for lesions elsewhere, scalp, elbows, knees, gluteal cleft, can provide clues. So this problem, hidden psoriasis, can cause itching, soreness, and fusing. While topical corticosteroids are used, their long-term use needs care on the valvular skin. Vitamin D analogs, for example calcipotriol, can be effective but may cause irritation. Avoid tear preparations on the vulva. In severe cases, systemic therapy may be needed. Plasma cell vulvitis, also known as zone vulvitis, in males of glans penis, but we talk about ladies. So Plasma cell vulvitis presenting as striking, striking, well-demarcated, shiny, erythematose, fiery red or orange-red plaques, often with cayenne pepper spots, petechia. The exact cause is unknown, but it's characterized histologically by a dense infiltrate of plasma cells. Why it's so important? While benign, means no pre-malignant, it can cause significant soreness, burning, and dyspareunia. Itching is less common. It's often a diagnosis made after excluding other conditions, and biopsy is a key to confirm the characteristic plasma cell infiltrate. Can be refractory to treatment. Potent topical corticosteroids, topical calcineurin inhibitors, like tacrolimus, pimecrolimus, you name it. And occasionally intralesional steroids or even surgical excision for very localized, persistent lesions may be tried. No, why not? So about hidradenitis suppurativa. Hidradenitis suppurativa is a chronic inflammatory disease of the hair follicles in apocrine gland being scales, axilla, groin, vulva, perineal, buttocks. It's not an infection of sweet glands as once thought, but rather follicle occlusion leading to rupture, inflammation, abscesses, sinus tracts, and scarring. It has a strong association with smoking and obesity. Actually, we don't know why, but we know that. Strong association with smoking and obesity. So, hidradenitis suppurativa causes recurrent painful nodules, abscesses, draining sinuses, and disfiguring scars, leading to profound physical and psychological impact. Often misdiagnosed as recurrent boils or infections, leading to delays, inappropriate management. Treatment depends on severity, early staging, and includes lifestyle modifications, my beloveds, smoking cessation, weight management, topical and systemic antibiotics, often for anti-inflammatory effects actually, retinoids, hormonal therapies, anti-androgens, biologic agents, adalimumab, and surgical interventions, incision and drainage for acute abscesses, deroofing or wide excision for chronic diseases. Now, why biopsy is so crucial? Actually, golden. Many valvular inflammatory disorders share overlapping symptoms like itching, burning, redness. Even classic visual presentations can be misleading, especially if there is secondary infection or Lichen Simplex Chronicus. For instance, what looks like just eczema could be early lichen sclerosis or even valvular intraepithelial neoplasia. So, clinical importance. A valvular biopsy is relatively simple. Simple office procedure that provides definitive histological diagnosis, crucial for guiding appropriate treatment and assessing malignant potential. So consider biopsy for lesions that don't respond to initial empiric therapy, have atypical features and pigmented, ulcerated, nodular, or if there is a suspicion of malignancy. For example, valvular intraepithelial neoplasia or invasive cancer. Biopsy is almost always indicated for suspected lichen sclerosis or lichen planus. But biopsy, the most representative area, avoiding extensively excoriated or ulcerated zones if possible, of course, unless that is primary feature. Multiple biopsies may be needed for widespread or varied disease. So the term vulvodynia, what does it mean? Vulvodynia is a chronic valvular pain without an identifiable cause, often coexist or is exacerbated by inflammatory valvular conditions. Even when a specific inflammatory disorder is diagnosed and treated, a neuropathic pain component, there's always actually, component or a central sensitization can persist. Yeah. So, clinical issue of that. Chronic valvular symptoms, especially pain and itch, severely impact quality of life, leading to anxiety, depression, sleep disturbances, and relationship difficulties, of course. So, dyspareunia is a common consequence of many valvular inflammatory disorders due to pain, anatomical changes, stenosis, scarring, or fear of pain. These can strain intimate relationships and affect self-esteem. Management should be multidisciplinary, addressing not just the dermatological condition, but also pain management. For example, tricyclic antidepressant, anyway. Psychological support, why not? Counseling, cognitive behavioral therapy, and pelvic floor physiotherapy. Acknowledging and validating the patient's experience is crucial, like on any other always pathological conditions, my beloveds. Of course, it's crucial. Now about provoked vestibulodynia, formerly vulvar vestibulitis syndrome. So provoked vestibulodynia is the most common cause of dyspareunia in premenopausal women. It's characterized by sharp pain upon touch or pressure the vaginal introitus vestibule. Introitus is a vestibule. While its exact etiology is complex, multifactorial, of course, neuropathic, of course, musculoskeletal, of course, hormonal, and so on. An inflammatory component, often with increased mast cell numbers or nerve fiber proliferation, is frequently implicated on its pathophysiology. Why it's so important? Diagnosis is made by history, so pain with intercourse, tampon insertion, tight clothing, gynecological exam, and a positive Q-tip test, so eliciting pain with gentle pressure from a cotton swab at the specific points in the vestibule, especially around the Bartholin gland ducts. Yes. It's vital to differentiate the problem from other causes of dyspareunia like lichen sclerosis, lichen planus, or active infections. However, provoked vestibulodynia can sometimes coexist or be triggered by these conditions. So management is often challenging and multimodal, including topical anesthetics, lidocaine, pelvic floor physiotherapy, cognitive behavioral therapy, actually no idea what is this, tricyclic antidepressants, gabapentinoid, and occasional surgical vestibulectomy for refractory cases. Addressing any underlying or coexisting inflammatory disorder is key, my beloveds. So that's it. That's all that I want to talk about. Questions concerning valvular problems. I suppose that's all. Yes, I clarified all key points, key questions that misunderstood by you and confused by you. Anyway, so thanks for your attention. Don't forget to follow and subscribe my Dr. Y YouTube channel as well as my private Dr. Y YouTube channel in Telegram. How to find this channel? Easy peasy. So you tap in searching mode Dr. Y, WHY, like question, no, without question mark. Dr. Y is me. Dr. WHY. You find it's a bot. Click start and you choose your plan. It's not costly at all. Stay blessed.